Hi guys, welcome back. The topic we're going to study now is chiari syndrome. You see, the baseline information would be that in the portal vein there would be ammonia rich blood, and the basic function of liver will be to detoxify this blood by combining ammonia with carbon dioxide and producing urea. But the problems in chiari would be that there would be a thrombosis developing in the hepatic vein. Like in this diagram, I've shown the left, the middle and the right hepatic vein. So the problem is starting secondary to a hematological disorder. Though I will compile a list of the various reasons why this disease can develop, but one of the important reasons is hematological disorders like polycythemia vera or PNH, where the thrombus will begin in one of the hepatic veins. Very soon it can obviously extend, and even the contralateral hepatic vein can also be involved. The technical definition of the word Budd-Chiari syndrome would be thrombosis. Remember the words here. A lot of guys casually answer thrombosis of the inferior vena cava, but your answer would be given as, though it is obviously involved subsequently. I mean, no big deal that the thrombus can extend into the IVC. That's definitely a distinct possibility occurring in the person, and the implications of that can be picked up on ultrasound because the caudate lobe will become bigger, because the caudate lobe directly drains into the inferior vena cava. But the technical definition should be answered as at least two or more than two hepatic veins are having development of thrombosis, and inferior vena cava involvement is secondary to this. As I explained, there are two important lobes in the liver that we always read, quadrate and caudate. So what I am speaking about at the moment is that anatomically, you're all aware of the fact that caudate lobe directly drains into inferior vena cava. So if I'm gonna have an obstruction in the IVC, then the caudate lobe of the patient on ultrasound will become enlarged. It's not all the cases that the IVC will be involved. So obviously I will have to use Doppler for this condition. I might have to use hepatic venography for identification, but yes, enlargement of the caudate lobe, if present, is a welcome additional fact over hepatic venography and Doppler. The standard presentation of this patient will be secondary to this obstruction. There would be congestion developing in the liver. So what I've shown here with these plus marks is that the congestion will be transmitted, and therefore there would be a development of centrilobular necrosis. You see, once this centrilobular necrosis will occur, patient can also develop fulminant hepatic failure. So there are two ways this disease can develop. Either you can have a chronic presentation or you can have an acute presentation. Most of the time, if they give you a scenario for hematological disorder, they might actually deliberately in the exam begin with an acute manifestation where there would be a tender hepatomegaly. Now, whenever you read about tender hepatomegaly, you think in terms of viral hepatitis, you think in terms of amoebic liver abscess. But in this particular case, it is not an infection, it is a thrombosis which is contributing to the problems. And because the obstruction is occurring primarily distal to the sinusoids, so I'm going to classify this not as a post-sinusoidal cause. Post-sinusoidal cause of portal hypertension would be like taking a herbal teas, or like in PSM, you read about endemic ascites, right? That endemic ascites is called by pyrrolizidone alkaloids, and those pyrrolizidone alkaloids can contribute to development of damage to the area which is distal to the sinusoids per se. So post-sinusoidal cause of portal hypertension should be answered as hepatoveno-occlusive disease, thanks to the herbal teas of the unofficial and the poor quality, I would say, and endemic ascites due to pyrrolizidone alkaloids. But if they specifically asked you with respect to Budd-Chiari, you will answer this not as a post-sinusoidal but as a post-hepatic cause. I want to highlight this fact, put it on record now. That is, this would be classified as a post-hepatic cause of development of portal hypertension, and therefore in the MCQ, he can also describe ascites. That's a different aspect, that whether it will occur slowly or whether it will occur fast. And I said in the question, just to make it dramatic and sound like an acute abdomen, because the pain will be intense due to sudden stretching of the liver. So whenever you read about tender hepatomegaly, not only should you be thinking in terms of viral hepatitis, amoebic liver abscess, even heart failure, but even Budd-Chiari syndrome should definitely be considered. Over and above this, I can also say that if a person is suffering from hydatid cyst, you see, hydatid cyst itself may cause a painless hepatomegaly, but now what I've shown in the diagram is that this hydatid cyst is enlarging in size, and it will go and press on the hepatic vein. It could initially press on one of them, then subsequently the second one as well. So hydatid cyst can be classified as a secondary cause of why Budd-Chiari syndrome would be developing. In the primary cause I mentioned, it was hematological problem. Or let's take up another scenario. I have shown here a liver tumor. This could be an intrinsic liver tumor, that's hepatocellular carcinoma. It could be metastasis. You see, multiple mets could be pressing on multiple hepatic veins, resulting in this presentation also. So in some questions, there is a possibility that if he says the word secondary, it means the problem is not lying inside the blood vessel, it's coming from outside. It could be a tumor, that's I've shown in green for representational purposes, or it could be a hydatid cyst or a parasitic cyst for that matter of fact. So once we have assimilated this information, let us just compile a list of the common causes why this would be developing in decreasing order of prevalence, starting with hematological conditions. The first and the foremost condition that you will answer will be polycythemia vera, which is secondary to JAK2 mutation. Or in the MCQ, I mean, if he thinks that that's too obvious and you will be able to crack it, he will talk about a condition where PIGA gene is defective, paroxysmal nocturnal hemoglobinuria. You are aware from your pathology classes that in polycythemia vera anyway, the erythrocytosis will explain the sluggish circulation in the liver and the thrombosis component. But in paroxysmal nocturnal hemoglobinuria, there is a problem with CD59, which is on the platelets. It prevents intrinsic platelet activation. I mean, in our body, platelets get activated when there is a injury. But in this patient, the platelets tend to express more of thromboxane E2 in the absence of CD59, and therefore there can be a platelet aggregation occurring even in the absence of trauma. As a result of it, the thrombus formation chances will increase. You see, CD55 is absent on the RBC, so they become susceptible to complement-mediated destruction. So that's why we read about anemia, and that anemia can be fairly extensive. So hemoglobin can come in the urine, that would be hemoglobinuria. But on the other hand, if it is CD59 and both aspects are present in PNH, I mean, PNH is not a disease of the quantity of RBC, WBC platelet, it is a disease of quality. RBCs are of poor quality. What I mean by poor quality, CD55 is not there, so complement will destroy it. CD59 is absent, so platelets are getting activated even without an extrinsic stimulus, that is in the form of a trauma, and therefore the clumping of the platelets will contribute to a hypercoagulable state. So in the question, most of the time, initially he is going to describe a patient who's suffering from a hematological disorder, and then subsequently there would be a triad of tender hepatomegaly plus ascites. That's one of the standard features, ascites. Why? Because there will be portal hypertension and there would be right upper quadrant pain developing in the patient. I'll describe the triad subsequently. I've already said it verbally. Features would be presence of right upper quadrant pain plus ascites plus a hepatomegaly. Apart from the hematological aspects, let us assume a patient is having a hypercoagulable state that is causing deep vein thrombosis. Now, there are lots of causes of deep vein thrombosis which have been discussed even in the topic of pulmonary embolism. So, this gives me one more opportunity to describe them. You see, we have a clotting system in the body, we have a anti-clotting system in the body. So, a protein C, protein S and antithrombin 3 will become lesser. Due to genetic reasons, if they are lesser, then the clotting system will be unopposed, and unopposed clotting system can contribute to a hypercoagulable state. Let's look at one more, which happens to be the most common hypercoagulable state. You are aware from your pathology classes that one of the commonest hypercoagulable state is factor 5 laden mutation. Let us understand what happens here. You see, in our body, factor 5 and protein C are in interaction with each other and they keep each other's activity in check. But in factor 5 laden mutation, factor 5 amount is okay, but the binding with protein C, I can say, is defective. As a result of it, protein C is not able to keep a check on factor 5, and therefore factor 5, which plays an important role in the extrinsic system of clotting, initiates a clot, and that could be in the hepatic veins of the patient, and then it can spread to even the inferior vena cava. In the question, he can mention hypercoagulable states like postpartum. In fact, this would be relatively easier for you to pick up. I mean, hypercoagulable state, when I say postpartum state, or the older versions of oral contraceptive pills. You see, nowadays we use the word combined oral contraceptive pills. The problem in these would be the amount of estrogen. Now, the current generation of OCPs is very unlikely to cause this, but in the older generation of OCPs, the estrogen amount was up to 30 mics or even higher. So estrogen was causing a hypercoagulable state then I've already explained to you, it could be a secondary Budd-Chiari syndrome, it could be tumors. It could be a hepatocellular carcinoma post hepatitis B, hepatitis C in the patient. It could even be renal cell cancer, which is enlarging in size, or from the pediatric perspective, it could be Wilms tumor, which is enlarging and pressing on the liver and is compressing the hepatic veins. A little far-fetched, but yeah, I mean, adjacent area tumors could also be pressing on the liver, resulting in this kind of a manifestation. Or it could be mets to the liver as well. I mean, mets to the liver can be coming from colorectal cancer, it could be coming from breast cancer. In fact, most of the GI organs will ultimately metastasize to the liver itself, thanks to the portal vein. And therefore mets I have not written here because that would be relatively easier for you to pick up. Then would be infections. It could be a parasitic cyst, most of the time described, caused by Echinococcus granulosus, that is hydatid cyst. Then could be connective tissue disorders also, because in rheumatology also we study about Budd-Chiari syndrome. So what are the diseases? One of the important one will be antiphospholipid antibody syndrome. If you have listened to my discussion in rheumat, you would have remembered that there is a special antibody here by the name of anti-beta 2 glycoprotein antibody. Let us see what it does. This antibody is going to stimulate the intrinsic system of clotting. It's going to send the intrinsic system of clotting into an automatic mode. Just like in factor V Leiden mutation, it is the extrinsic system of clotting that goes into an automatic mode, and therefore thrombus formation occurs. In antiphospholipid antibody syndrome, where you have recurrent abortions, I mean, a hot favorite of our examiners nowadays is APAS, antiphospholipid antibody syndrome. Associated with SLE, can be without SLE also, but this auto activation of the intrinsic system, the auto activation is occurring thanks to the antibody. I mean, in you and me, we don't have this antibody, right? In our body, the extrinsic or the intrinsic system is activated whenever there is trauma. But in this particular case, you will inform this lady that, ma'am, in you, your clotting cycle is on an automatic mode, which is causing not only thrombosis in your uterine veins or uterine artery even, which is causing a recurrent fetal loss, recurrent abortions, but even in the liver, you could be having thrombus formation. In fact, thrombus in these patients can be formed even in the brain, so stroke can occur, even myocardial infarction can occur. So fairly a very dangerous disease, I would say. To complete the list, I want you to remember two more connective tissue disorders. One is sarcoidosis. That's understandable. Non-caseating granulomas. Sarcoidosis can anyway involve multiple organs in the body. Liver is one of them. Then can be Behçet's disease as well, where Behçet's normally is oroocculogenital, but yeah, liver involvement is also described in the textbook for Behçet's as well. The basic message is Behçet's is also vasculitis. So that vasculitis can involve hepatic veins also. And once, I mean, there's an inflammation in the wall of the blood vessel, then thrombus formation can occur. So the logic in Behçet's is the vasculitis component, the hepatic vein would get involved. Then there could be anatomical issues also. Another aspect which is to be remembered by you would be anatomical defect with respect to the hepatic veins and even the IVC, which could be called as a membranous defect. What it simply means is that there is an anatomical difference in the hepatic veins of this person as compared to you and me, and the membranes which are present are predisposing to thrombus formation. If a patient is on total parenteral nutrition, now when we have to give total parenteral nutrition, we preferably try to put in a central line because of the thrombophlebitis aspect, and we can give it via the subclavian vein. But let me say, the upper part of the body is burnt, and therefore due to the injuries in the upper part of the body, in and around the shoulder, around the neck area, I was not very comfortable putting a subclavian vein catheter, so I put a catheter in the inferior vena cava. And therefore this patient of extensive burns, who is on total parenteral nutrition, because I have put a catheter, and the catheter is obviously a foreign body, the thrombus formation can definitely develop. So these are some of the important causes why you could be having Budd-Chiari. Let's now look at the clinical manifestations, and in most of the questions he will make it sound as if you are reading a question of a patient having cholecystitis, because it will begin by describing sudden onset right upper quadrant discomfort. In fact, when you do ultrasound, because anybody with right upper quadrant pain in the casualty, you will do an ultrasound to rule out possibility of gallstones. There are no gallstones. So you're wondering, okay, if it's not calculus, it could be acalculous cholecystitis. Now, what is present in this particular case, or what is present in this triad, that will tell you that this is not a acalculous cholecystitis, would be a feature that will take a few hours to develop, and therefore there's a possibility that initially this guy is kept in the casualty because he came to me with sudden right upper discomfort as a case of cholecystitis. Therefore, what I will notice is, because this guy will develop a post-hepatic portal hypertension. Therefore, due to obstruction in the hepatic veins, there would be increased pressure in the portal vein also. That will be reflected in the pressure in the splenic vein. So there will also be a splenomegaly subsequently, but splenomegaly will not cause symptoms at the moment. But because the hydrostatic pressure in the blood vessels is more, so from the splenic bed, there would be more leakage, more transudation occurring of the fluid, which will contribute to ascites in this patient. So abdominal discomfort with abdominal distension will occur in this chap. When I do a physical examination, I am also noticing the fact that the span of the liver is substantially increased. You see, when it comes to cholecystitis, whether it is calculus or acalculus, liver span remains normal, but this is going to be a gross distension of the liver thanks to the physical obstruction which is present. So hepatomegaly will definitely make you think in terms of throwing the diagnosis of cholecystitis out of the window. If the diagnosis is not made because of the centrilobular necrosis that sets in, then jaundice will also start occurring in the patient. If the liver is compromised, even kidney can be involved, so there can be hepatorenal syndrome. Hepatorenal syndrome is a condition in which there is a intrahepatic vasoconstriction. Splanchnic vessels, intestinal vessels are dilated, but inside the liver, there is a intrahepatic vasoconstriction. The reason for that is that whenever there is damage in the liver, the endothelial nitric oxide synthesis inside the liver. Remember my words, nitric oxide is produced inside the liver also. That synthesis is hampered. Nitric oxide is a vasodilator, no? So I said intrahepatic vasoconstriction, and outside the liver splanchnic bed there is a vasodilation. So hepatorenal syndrome occurs because of imbalance that's created due to intrahepatic vasoconstriction and I would say splanchnic vessel dilation. In fact, I can put it in a much more simpler way. I said because there is a splanchnic vasodilation, so therefore kidney will get a finding, or kidney will feel as if there is a apparent hypovolemia or there is a apparent underperfusion. I repeat my fact once again. I said because in this condition there is a splanchnic vasodilation due to more production of nitric oxide in the splanchnic bed and rather less in the liver. I said imbalance, right? So splanchnic blood vessels are dilated, inside the liver are constricted. Once those splanchnic vessels are dilated, the kidney will get a impression as if there is a underperfusion. Whenever there is a underperfusion, what does the kidney do? One, it starts producing more of antidiuretic hormone, it starts producing more of aldosterone, and both will draw in water, and therefore ascites of the patient will begin to worsen. At the same time, the kidney will also begin to fail, so acute kidney injury like manifestations can be occurring, and at the same time the kidney is responding by producing large amounts of antidiuretic hormone as well as aldosterone. So salt and water are increasing, the patient will become puffy, bloated, puffy eyes can develop, pedal edema can develop. That would obviously be, it will take some time. I'm not saying that it's going to happen immediately, but because there is a splanchnic vasodilation, so the end result will be that there can also be a renal failure in these patients. In fact, there's a separate video on hepatorenal syndrome that is present in the app, so please go through that. But anuria, oliguria, I would say renal malfunction can be developing in these patients. The pedal edema component is explained by the volume expansion that occurs. I already said that aldosterone would be contributing to this. So most of the time this would be the acute presentation. And if it is going to be chronic, if it's going to be gradual onset, then he is going to describe features of portal hypertension also occurring in the patient. That would mean that there could be description of caput medusae, because it will take some time for the collaterals to develop in portal hypertension. So caput medusae could be described, then even a variceal bleed could be developing. So chronic presentation results in standard features of portal hypertension, which are discussed separately in the app again. So I'm not describing those features of portal hypertension again, but yes, the point is, once you are having these portosystemic collaterals coming into picture, once the spleen starts becoming bigger in size, one on hematological evaluation, CBC platelet count start decreasing because the spleen will eat away into the platelets. Hypersplenism can be a manifestation of splenomegaly secondary to portal hypertension. So the appetite of the spleen will increase. That will explain thrombocytopenia and liver disease. So I know that portal hypertension is set up. So chronic presentation can also be given, acute can also be given, and there's a probability that in the exam he would like to try and give you the acute presentation. Why? Because there's a high probability that we can think in terms of viral hepatitis, or even heart failure has a tender hepatomegaly. amoebic liver abscess at enterohepatomegaly. So we'll try to, or there's a possibility that we might get misdirected towards those. But if you get the data right, I mean, if you just focus on these three words carefully, if you pick up those points in the question, right upper quadrant pain plus ascites and hepatomegaly, you would be much more comfortable answering this as a query, but chiari. Now let's look at the investigations. The first investigation that I'll be doing in this case would be ultrasound, and simultaneously I will be having the facility of Doppler as well to check up for the signals for the flow of blood that might be hampered. One of the advantages of doing ultrasound in the casualty would be that the standard causes of cholelithiasis can be ruled out. Cholecystitis can be ruled out. I mean, gallbladder is perfectly normal in this case, so I'm ruling out other concomitant pathologies. And then the Doppler will definitely show me problems in this patient because there would be a decrease in the signal since the flow is hampered. In fact, I would just like to highlight an image here where you will be able to visualize this big thrombus that I have highlighted stuck bang in the hepatic vein. You can see the hepatic vein, you can see it's branching, the features. This is a plain ultrasound that is actually showing a thrombus formation. So the echo texture is definitely telling us that there's a problem in the vein per se, and the combination of ultrasound and Doppler mostly in our hospitals would make us think in terms of Budd-Chiari. If ascites is substantial, I can be going in for ascitic tap. This would definitely be a diagnostic ascitic tap or paracentesis occurring, and when I will check the serum albumin ascites gradient, because it is due to increased pressure, because this would be having a transudative nature, because it is because of the increased hydrostatic pressure, therefore the values of SAG will be more than 1.1. It's a different issue that if we will talk about ascitic protein, ascitic fluid protein, in the early part of Budd-Chiari syndrome, albumin can still leak across, because at the moment there is no fibrosis that is occurring. It's an acute onset damage, so proteins can leak. So there's a possibility that the initial part of the illness, he might actually write the fact that the ascitic fluid protein is on the higher side. The reason why it is higher is primarily because proteins can leak, but as there's a damage to the architecture, as there's a subsequent fibrosis, then the ascitic fluid proteins values will begin to reduce. So if you can remember this ascitic fluid protein values also given in the question, I mean early versus late, great, but otherwise you mainly need to remember that the SAG values will be more than 1.1. Every time there's a portal hypertension, every time there's an increase in pressure, SAG values will be more. If there's going to be infection, if there's going to be like tuberculosis, carcinomatosis, or carcinoma based malignancies which metastasize to the peritoneum, then the SAG values will be less than 1.1, and that's again separately discussed with respect to ascites. When I will be doing a liver function test in this patient, serum bilirubin values can be increased. It could be initially normal, maybe the second LFT of the patient will show enlargement, but the liver enzymes SGOT, SGPT will definitely, because I was describing central lobular necrosis, so the liver enzymes are going to be grossly elevated. Nowadays we are also using MRI abdomen. Obviously, like if you are having a Doppler or ultrasound in your hospital, no issues, you can still make a diagnosis. MRI abdomen is being increasingly used for this condition, though if he says overall what is the best test to confirm the diagnosis, then ideally I should be having access to interventional radiography, and I should be able to do a hepatic venography. Now most of the time this is not gonna be available, so I have mentioned what is ideally suitable to demonstrate at least 2 hepatic vein thrombosis. But if this is not available, then the answer should be given as MRI. If it is not available, obviously Doppler or a combination of Doppler with ultrasound can be the initial screening procedure for this patient. Once we have identified this patient, our next job would be to treat him. And now I would like to describe the discussion into 2 parts, the acute version versus the chronic version. If I say the acute version, then according to EASL guidelines, the European Association, right? The basic treatment for acute onset Budd-Chiari syndrome would be to perform a balloon angioplasty and get rid of the thrombus in the hepatic veins. Like in stroke, we get rid of the thrombus by doing a MRCI, a mechanical embolus retraction. Like in percutaneous coronary intervention, in myocardial infarction, we get rid of a thrombus. Similarly, here we're getting rid of a thrombus by doing a balloon angioplasty. But this facility may not be available regularly in our hospital. So what are we going to use? We are going to use heparin for this patient. It could be plain heparin, it could be low molecular weight heparin based on the facilities which are available. But if he gives you a chronic scenario, If there's a chronic presentation of Budd-Chiari syndrome, then there definitely will be findings of portal hypertension. Because of this portal hypertension, the ascites that will develop in these patients will not be once but would be recurrent. In fact, these patients would be having refractory ascites. That refractory ascites, even if you are gonna do a paracentesis, a large volume paracentesis, giving even albumin, still the fluid will come back. So you need to ideally go in for procedure by the name of TIPS, that is transtubular intrahepatic portosystemic shunting, so that I can prevent the redevelopment of refractory ascites in the patient. If the MCQ says acute, your primary answer would be given as balloon angioplasty. If it says chronic, the answer should be given as TIPS, primarily to treat the portal hypertension component, which is otherwise untreatable, I would say. Definitely some relief in the severity of ascites can be with the usage of diuretics. I can give combination of spironolactone with furosemide. That furosemide is going to cause obviously hypokalemia, so I'll keep a watch on the electrolytes component, but I'm trying to reduce the problems of the patient. And if it is a development of end stage liver disease, if the patient is deteriorating towards decompensated cirrhosis and the complications of decompensated cirrhosis are becoming obvious, we will in end stage liver disease anyway be making the patient and informing the patient and the relatives to undergo orthoptic liver transplantation. So for chronic, it's relatively easier, I would say. Tips: drugs, supportive care, and end-stage liver disease management is liver transplantation. But in acute, which is more probably asked in the exam, it would be balloon angioplasty. And this entire clinical presentation that I have made before you for right tummy discomfort, ascites and hepatomegaly could be described in a question that will begin with a hematological disorder. The history will be corresponding to PNH, or it could be a history corresponding to polycythemia vera. Both are totally different disorders. One is a myeloproliferative disorder, another was acquired stem cell disorder, but the common thing between the two will be a development of stasis. The reasons are different as I've enumerated. It could be erythrocytosis, it could be intrinsic platelet activation even without any stimulus or trauma, or like in PNH, right? The hypercoagulability component is mainly related to the platelets which are malfunctioning. They're overactive, they're overeager. Instead of waiting for an external stimulus, they are working on their own. So the hypercoagulable state would develop in this patient. So anytime, I mean, you read a question of a hematological disease with especially the ones that I've highlighted with the problems developing, you have to think in terms of the current disorder that I've explained. And obviously if chronic is there, then he will love to ask you regarding post-hepatic causes of portal hypertension. I'll try to trouble you with a post-sinusoidal cause, which I've highlighting once again: poor quality herbal teas. And in PSM you study about crotolaria, right? That's a weed, that's a food adulterant, and that food adulterant can contribute to endemic ascites. So remember, endemic ascites is actually a damage to the post sinusoidal area, right? Not exactly the hepatic vein, but prior to the hepatic vein the lesions would be present. So these are the technical details that I would like you to remember for this topic. Keep hammering, guys, keep focus on for all these aspects that I've highlighted. And the more you learn, knowledge is power. I mean, after all, a patient or a client is going to pay you for the knowledge that you have in a consultation. So initially this looks a little overbearing, but all of you are brilliant people, all of you have cleared so many exams. If you come this far, you will definitely break on to the other side as well. Thank you so much, guys, for hearing me out.